So I was given the task of actually talking about too many clicks, all those boxes. And so starting this discussion, what we hear from nurses and clinicians, they tell us that there's an overabundance of clicking and movement from screen to screen in order to document clinical care. So one goal, I think, that as we consider improvement strategies, we want to consider is balancing all those clicks with quality clinical documentation. And this was raised in some of the discussion chat from our session number 1. So questions we might want to consider is, how do we balance the need for structured data for reporting standard, reliable, and comparable data versus unstructured data and that story that we all want? What constitutes quality clinical documentation? And we even saw some of this discussion in session 1, and I saw it again today as well. So, and then the question of how many clicks is too many clicks? So when Dr. Sandstack actually asked me to do this, I went to some of our own data within a study that we did in 2015 to examine the satisfaction of nurses across Texas with their electronic health records, while at the same time we control for the maturity of the system. And we repeated this study in 2020, just recently. And unfortunately, I have to report that I don't think it will be surprising to anyone, but we have no significant improvement in satisfaction. The maturity of the systems are improving, but satisfaction is not. We asked the nurses also in an open-ended text question, is there anything else you'd like to tell us about your electronic health record or your clinical information system? And out of, in 2015, we had 1,177 respond. In 2020, 1,113. So out of that, we got roughly 300, 350 that gave us an earful. So in terms of clicking those boxes, here's what the nurses are saying. Viewing a specific order takes clicking through at least 4 screens to find out what the nurse really needs to know. I feel patient safety is at risk. Computer charting instills education on what to click, but no free thinking, that critical decision-making component. Often they tell us it's missing. The system isn't user-friendly. You have to click here, click there, click back again, and so on in order to just do one assessment. EMRs were only developed for attorneys and accountants in mind. They've absolutely turned nurses and physicians into box clickers for accountants and provide an electronic timeline for events for lawyers, which is a joke since it puts nurses in a position of creating a pseudo timeline which may or may not reflect real-time events. It's obvious that there was no consideration of the real workflow taken into account. Many nurses click through boxes in order to make the screen go away without really even considering what they're clicking away. So documentation suffers, therefore patients suffer. EHRs makes nursing harder and less efficient than paper documentation. So these are just a few samples, and there were many comments. So let's look at some of those themes in terms of narrative. There's consistency from 2015 to 2020. We had clearer themes that were larger themes in 2015, and they're more consolidated in 2020, but a lot of consistency. Patient safety and quality, the documentation, the legality issues nurses are concerned about. Time with the patient suffers. In some cases, nurses told us that they felt like they had more time with patients. Workflow, a lot around workflow, workarounds, particularly related to barcode administration, medication administration, communication, reduce clinician consultation between the interprofessional team. In some cases, they told us that it actually improves communication. Distress, and as our ethicists actually looked at some of this discussion in our text documentation, they not only said more distress was present, but at times there was a tone of moral distress. System design and usability, particularly related to interoperability. Unfortunately, it's still there in 2020. And then support, not enough support. They didn't feel like they were being supported administratively or from a competency training standpoint. A lot of these themes are consistent in 2020 as well. Nurses' role in providing care, that clinical workflow component, here's that communication. under this theme or topic, that distress and stress, but with a little bit different tone. They're more aggravated now. There's not that moral distress. There's a tone of aggravation, and also that they're much more confident in, they know what they want and they're not getting it. Reduced time with patients and inefficiencies, and then on to that whole system design piece where we've got redundant documentation, the role of leadership, concern around system design. Vendors are a lot of vendor comments in 2020. Reimbursement reporting, again, interoperability issues with system design, particularly device integration type issues. Concern around patient safety is often associated with that. And then quality of IT support, that's that whole support piece again. And there were some significant components of that. These narrative themes were reinforced with our quantitative data, so this was more of a mixed method approach to study. So looking again at some of the Texas effort to address some of these issues where we have worked with the Texas Nurses Association and Texas Organization of Nurse Leaders to determine, wow, what are we going to do about this? One of the other things that we asked was that the Texas Board of Nurse Examiners give us what's the incident of documentation challenges that we're seeing, because nurses were telling us that they had regulatory concerns with patient safety, quality of the data, et cetera. And so this is a control chart looking at from 07 all the way to 2018. We have not looked at this more recently, but those of you who use control charts will identify the red points or special cause variation headed up. Maybe we're doing a little bit better in 2018. Hard to tell without looking and projecting out further into 2020 and 2021. So lots of concerns, particularly with young nurses. We're seeing this under 5 years of practice. So not only are they trying to learn complex clinical, but they're trying to deal with these systems that don't always work for them, they work against them. So one of the things that was notable on my first slide was the structured versus unstructured data. And many of our systems are trying to mature their clinical data in order to use enterprise-wide data to improve quality, safety, population health, particularly now that we have COVID-19 on everybody's doorstep. So how are we going to balance minimizing documentation, minimizing clicks, when a lot of those clicks are all about structured data and they're about clinical protocols that we've built into order sets? So how can we balance what seems to make sense and improves quality and allows us to report structured data in a standardized, comparable way with the need for the unstructured data and more of that narrative? So the question of what constitutes quality documentation is kind of at the heart of it. So if we look at a piece of work that was done related to physician evaluation of documentation, clinical quality, here are 9 elements that I think most of us would agree make complete sense. We want up to date, we want accurate, we want thorough, we want useful, organized, comprehensible, succinct, synthesized, and internally consistent. So let's take a look at a nursing effort now, similarly, that actually maps pretty well to the physician quality components in this 9-domain piece of work. And this is some work we've done out of Texas Tech University Health Science Center and our simulation lab, where we're looking at how can we train clinicians within the clinical workflow to use the electronic health record in a way that would reinforce clinical quality of documentation and use of the EHR. So here are our 10 domains of that we are using that constitute best practice in use of the electronic health record for clinical documentation.
Susan, about a minute left, Susan. Thanks.
Okay. Documentation is honest, demonstrates professional integrity, is devoid of errors. Documentation is consistent with the clinical condition. It's complete with no gaps and omissions. Appropriate use of structured and unstructured data. Reflects clinical decision-making based on clinical evidence. Documentation aligns with scope of practice. It reflects timely reassessment of the patient, efficient, and documentation and actions reflect appropriate clinical decision support in terms of triggers and alerts that we may be getting. So is it too many clicks or is it a design and usability issue? There is a lot of documentation that the myth about that too many clicks is actually a myth, and that it really is about design and usability. So key points to consider are the number of clicks needed to complete the task. Not all clicks are equal. The number of clicks don't tell the story. They are relevant to the clinical workflow in support of our clinical decision-making. That's it.